welcome. Hello and welcome to my lecture on reproductive anatomy, part 1, external generative organs. To download my lecture deck, please go to my WordPress site, Docina o Vagina. The references for this lecture are Comprehensive Gynecology 7th edition and Williams Obstetrics 25th edition. And this is the outline of my lecture. First, we have the vulva. So the vulva is also called pudendum or pudenda and is a collective term for the external genital organs that are visible in the perineal area. So the vulva consists of the following: the Mons Pubis, the Labia Majora, the Labia Minora, the hymen, the clitoris, the vestibule, the urethra, the Skene's glands, Bartholin's glands, and the vestibular bulbs. The boundaries are the following. So it's the Mons Pubis anteriorly, the rectum posteriorly, or the perineal body, and then from one lateral genitocrural fold to the other. Okay, so the entire vulvar area is covered by keratinized, stratified squamous epithelium. The skin becomes thicker, more pigmented, and more keratinized as the distance from the vagina increases. The vulva receives innervations and vascular support from the pudendal nerve. Vulvar trauma such as straddle injuries frequently results in large hematomas or profuse external hemorrhage. The richness of the vascular supply and the absence of valves in vulvar veins contribute to this complication, and the abundant vascularity of this region promotes rapid healing with low incidence of wound infection in episiotomies or obstetric tears of the vulva. Second is the Mons Pubis. So the Mons Pubis is this area here, that fatty rounded eminence that develops hair after puberty. So it is directly anterior and superior to the symphysis pubis. The hair pattern, or what we call the escutcheon, of most women is triangular. Genetic and racial differences produce a variety of normal hair patterns, with approximately 1 in 4 women having a modified escutcheon that has a diamond or male-like pattern. Next, we have the labia majora. So these are two large longitudinal cutaneous folds of adipose and fibrous tissue. So each labia majora is approximately 7 to 8 centimeters in length and 2 to 3 centimeters in width. So the labia extends from the Mons Pubis anteriorly to become lost in the skin between the vagina and the anus in the area of the posterior fourchette. The skin of the outer convex surface of the labia majora is pigmented and covered with hair follicles, and the thin skin of the inner surface does not have hair follicles but has many sebaceous glands. The labia majora have both sweat and sebaceous glands. The apocrine glands are similar to those of the breast and axillary areas. The size of the labia is related to fat content, and usually the labia atrophy after menopause. The labia majora are homologous to the scrotum in the males. The subcutaneous fatty tissue of the labia majora and the Mons Pubis are in continuity with the fatty tissue of the anterior abdominal wall. So infections in this space such as cellulitis and necrotizing fasciitis are poorly contained and may extend cephalad in a rapid fashion. The round ligaments also terminate at the upper borders of the labia majora. The fat mass of the labia actually provides bulk to the labia majora and is supplied by a rich venous plexus. Now, during pregnancy, this vasculature may develop varicosities, especially in multiparas, from increased venous pressure created by the enlarging uterus. So, they appear as engorged tortuous veins or as small grape-like clusters, but they are typically asymptomatic and require no treatment. The fourth is the labia minora. So each labia minora, this one, is a thin tissue fold that lies medial to each labium majora. The labia minora extends superiorly, where each divides into 2 lamellae. From each side, the lower lamellae fuse to form the frenulum of the clitoris, and the upper lamellae merge to form the prepuce. Inferiorly, the labia minora extend to approach the midline as low ridges of tissue that join to form the fourchette. This one is the fourchette. The labia minora are composed of connective tissue with numerous vessels, elastin fibers, and very few smooth muscle fibers. They are supplied with many nerve endings and are very sensitive. Thinly keratinized stratified squamous epithelium covers the outer surface of each labium. On their inner surface, the lateral portion is covered by the same epithelium up to a demarcating line, which we call the heart line. This one. Medial to this line, each labium is covered by squamous epithelium that is non-keratinized. The labia minora lacks hair follicles, eccrine glands, and apocrine glands. However, sebaceous glands are very numerous. Next, we have the clitoris. This is a short, cylindrical, erectile organ at the superior portion of the vestibule. The clitoris rarely exceeds 2 cm in length and is composed of a glans, a corpus or body, and 2 crura. The 2 crura attach to the periosteum of the symphysis pubis. The body has 2 cylindric corpora cavernosa composed of thin-walled vascular channels that function as erectile tissue. Now, the clitoris is the female homologue of the penis in the male. The clitoral blood supply stems from branches of the internal pudendal artery. Specifically, the deep artery of the clitoris supplies the clitoral body, whereas the dorsal artery of the clitoris supplies the glands and prepuce. Next, we have the vestibule. Okay, so this is the lowest portion of the embryonic urogenital sinus. It is the cleft distal to the vagina between the labia minora that is visualized where the labia are held apart. So this is the vestibule here. So the vestibule extends from the clitoris to the posterior fourchette. So the orifices of the urethra and vagina and the ducts from the Bartholin glands open into the vestibule. Within the area of the vestibule are the remnants of the hymen and numerous small mucinous glands. In adult women, the vestibule is almond-shaped that is enclosed by the heart line laterally. So as I've said, the heart line is around this part here. And the external surface of the hymen medially, the clitoral frenulum anteriorly, and the fourchette posteriorly. The vestibule is usually perforated by 6 openings. So we have the urethra, the vagina, the 2 Bartholin's gland ducts, the 2 ducts of the largest paraurethral glands, which are the Skene glands. The Skene glands is this one. So it's very near the urethra. So the posterior portion of the vestibule between the fourchette and the vaginal opening is what we call the fossa navicularis. So this is the part where the fossa navicularis is. It is usually observed only in nulliparous. So next we have the Skene glands. These are also called the paraurethral glands and are branched tubular glands that are adjacent to the distal urethra. So in this picture we have the Skene glands here. Okay, it's very near the urethra. The ducts open into the area just outside the urethral orifice, and the Skene glands are the largest of the paraurethral glands. Clinically, inflammation and duct obstruction of any of the paraurethral glands can lead to urethral diverticulum formation, and Skene glands are homologous to the prostate in the male. Okay, next we have the Bartholin's glands, or what we call the greater vestibular glands. These are located immediately beneath the fascia at about the 5 and 7 o'clock position. So this will be the 7 o'clock position and the 5 o'clock position. But other authors would say it's the 4 and 8 o'clock position. So this is located in the posterior lateral aspect of the vaginal orifice. This is about the size of a pea. So this is composed of a cuboidal epithelium, and the duct from each gland is lined by transitional epithelium and is approximately 2 cm in length. As I've said, it's about the size of a pea. So Bartholin's ducts open into a groove between the hymen and the labia minora. Bartholin's glands are homologous to Cowper glands in the male. And following trauma or infection, either duct of the Bartholin's glands may swell and obstruct to form a cyst, which we call the Bartholin's gland cyst. Now, if this Bartholin gland cyst become infected, they become very, very painful, and that's what we call the Bartholin's gland abscess. Next, we have the vestibular bulbs. So, the vestibular bulbs are two elongated masses, as you can see here in this picture. So, these are elongated masses of erectile tissue situated on either side of the vaginal orifice. So, each bulb is immediately below the bulbocavernosus muscle. The distal ends of the vestibular bulbs are adjacent to the Bartholin's glands, and they are homologous to the bulb of the penis in the male. Next, we have the hymen. So, the hymen is a membrane of varying thickness that surrounds the vaginal opening more or less completely. Over time, the hymen transforms into several nodules of various sizes, which we call hymeneal or myrtiform caruncles. So, next we have the vagina. So, the vagina is a musculomembranous tube, as you can see here. So, it's a tube-like structure that's musculomembranous and that extends to the uterus and is interposed lengthwise between the bladder. So, this is the bladder and the rectum. So, this will be the rectum. Okay, so it's located between the bladder and the rectum. So, anteriorly, the vagina is separated from the bladder and urethra by a connective tissue which we call the vesicovaginal septum. So, this will be the vesicovaginal septum. So, posteriorly between the lower portion of the vagina and the rectum, similar tissues together form the rectovaginal septum. So, the rectovaginal septum will be this one. Okay. So, the upper fourth of the vagina is separated from the rectum by the rectouterine pouch, which is also called the cul-de-sac or the pouch of the Douglas. So, this will be that part here. Okay. So, the vaginal length varies considerably, but commonly the anterior wall measures about measures about 6 to 8 centimeters, and we have a relatively longer posterior vaginal wall which is about 7 to 10 centimeters. So this one is about 7 to 10 centimeters. Okay, so the upper end of the vaginal vault is subdivided by the cervix into anterior, posterior, and two lateral fornices. Okay, so clinically, the internal pelvic organs usually can be palpated through the thin walls of these fornices. So here in this picture, we have the fornices. This is the posterior vaginal fornix, and this is the anterior vaginal fornix. So the vaginal lining is composed of non-keratinized stratified squamous epithelium and underlying lamina propria. In premenopausal women, this lining is thrown into numerous thin transverse ridges, which we call the rugae. So in this picture, these are what we call the rugae. Okay, so this line the anterior and posterior vaginal walls along their length. Deep to this, a muscular layer contains smooth muscle, collagen, and elastin. So beneath this muscularis lies an adventitial layer consisting of collagen and elastin. The vagina lacks glands, so instead it is lubricated by a transudate that originates from the vaginal subepithelial capillary plexus and crosses the permeable epithelium. Now, due to increased vascularity during pregnancy, vaginal secretions are notably increased, and this may be confused with amniotic fluid leakage. After birth-related epithelial trauma and healing, fragments of stratified epithelium are embedded beneath the vaginal surface. Now, this buried epithelium continues to shed degenerated cells and keratin, and as a result, epidermal inclusion cysts, which are filled with keratin debris, may form. Now, the vagina has an abundant vascular supply. The proximal portion is supplied by the cervical branch of the uterine artery and by the vaginal artery. The latter may variably arise from the uterine or inferior vesical artery or directly from the internal iliac artery. The middle rectal artery contributes blood supply to the posterior vaginal wall. Okay, so the distal walls also receive blood supply from the internal pudendal artery. Okay, this part here. Okay, so the vessels supplying each side of the vagina course medially across the anterior and posterior vaginal wall, and they form a midline anastomosis. An extensive venous plexus also surrounds the vagina and follows the course of the arteries. So for the lymphatics, so from the lower third along with those of the vulva, drain primarily to the inguinal lymph nodes. So this will be the lower third. Okay, so that drains into the inguinal lymph nodes. Those from the middle middle third drain into the internal iliac nodes, and those from the upper third drain into the external, internal, and common iliac nodes. Because of the low density of nerve endings in the upper two-thirds of the vagina, so this will be the upper two-thirds of the vaginas that lack nerve endings, women are sometimes unable to determine the presence of a foreign body in this area. Now, this explains how a forgotten tampon may remain unnoticed for several days in the upper part of the vagina until its presence results in a symptomatic discharge or abnormal bleeding or odor. Okay, so next is the perineum. Okay, so this is a diamond-shaped area between the thighs. So, perineum is essentially this area. So, that area between the thighs. Okay, so boundaries are the symphysis pubis anteriorly, the ischiopubic rami and ischial tuberosities anterolaterally, the sacral tuberous ligaments posteriorly, and the coccyx posteriorly. Okay, so an arbitrary line joining the ischial tuberosities divides the perineum into the anterior triangle. This is the anterior triangle. There. And the posterior triangle, which we call also as the anal triangle. Okay. So the anterior triangle is also called the urogenital triangle. Okay, so the perineal body will be around this area, is a fibromuscular pyramidal mass found in the midline at the junction between these anterior and posterior triangles. Okay, so this is also called the central tendon of the perineum. This serves as a junction for several structures and provides significant perineal support. The bulbus spongosus, superficial transverse perineal, and external and anal sphincter muscles converge on the perineal body. So, the perineal body is incised by an episiotomy incision and is torn with second, third, and fourth degree lacerations. Now, we have the superficial space of the anterior triangle. So, as I've said, so this will be the anterior triangle or the urogenital triangle. Now, this triangle is bounded by the pubic rami superiorly, the ischial tuberosities laterally, and the superficial transverse perineal muscles posteriorly. So it is divided into superficial and deep spaces of the perineal membrane, and this membranous partition is a dense fibrous sheet that was previously known as inferior fascia of the urogenital diaphragm. The perineal membrane attaches laterally to the ischiopubic rami, medially to the distal third of the urethra and vagina, and posteriorly to the perineal body and anteriorly to the arcuate ligament of the pubis. The superficial space of the anterior triangle is bounded deeply by the perineal membrane and superficially by the coleus fascia. Now, the coleus fascia is a continuation of the scarpa fascia onto the perineum. Now, on the perineum, coleus fascia securely attaches laterally to the pubic rami and fascia lata of the thigh, inferiorly to the superficial transverse perineal muscle and inferior border of the perineal membrane, and medially to the urethra, clitoris, and vagina. As such, the superficial space of the anterior triangle is a relatively closed compartment. This superficial pouch contains several important structures. So we have the Bartholin's glands, the vestibular bulbs, the clitoral body and crura, branches of the pudendal nerves and vessels, and the ischiofibrinosus, bulbus spongosus, and the superficial transverse perineal muscles. Next, we have the deep space of the anterior triangle. Now, this space lies deep to the perineal membrane and extends up to the pelvis. In contrast to the superficial perineal space, the deep space is continuous superiorly with the pelvic cavity. It contains portions of the urethra, the vagina, and certain portions of the internal pudendal artery branches and muscles of the striated urogenital sphincter complex. Okay, so now we have the urethra. So the female urethra measures 3 to 4 centimeters and originates within the bladder trigon. The walls of the urethra consist of two layers of smooth muscle, as inner longitudinal and an outer circular. So this is in turn surrounded by a circular layer of skeletal muscle referred to as the sphincter urethrae or the rhabdosphincter. Approximately at the junction of the middle and third or lower third of the urethra and just above or deep into the perineal membrane, two strap skeletal muscles contain or called the urethrovaginal sphincter and compressor urethra are found. So together with the sphincter urethra, this constitute the striated urogenital sphincter complex, and this supplies the constant tonus and provides emergency reflex contraction to sustain continence. The blood supply for the urethra, so from branches of the inferior vesicle, vaginal, and internal pudendal arteries. The pudendal nerve is believed to innervate the most distal part of the striated urogenital sphincter complex, and somatic efferent branches from S2 to S4 that course along the inferior hypogastric plexus variably innervate the sphincter urethra. Now we have the pelvic diaphragm. This is found deep to the anterior and posterior triangles, and this broad muscular sling provides substantial support to the pelvic viscera. And this is composed of the levator ani and the coccygeus muscles. The levator ani contains the pubococcygeus, puborectalis, and iliococcygeus muscles. The pubococcygeus muscle is also termed as the pubovisceral muscle and is subdivided based on points of insertion and function. Now, this includes the pubovaginalis, puboperinealis, and puboanalis muscles, which insert into the vagina, perineal body, and anus, respectively. Vaginal birth conveys significant risk for damage to the levator ani or its innervation, and levator ani avulsion may predispose women to greater risk of pelvic organ prolapse. Now, we have the posterior triangle. Now, this triangle contains the ischoanal fossa, the anal canal, the anal sphincter complex, which consists of the internal anal sphincter, external anal sphincter, and puborectalis muscle. The branches of the pudendal nerve and the internal pudendal vessels are also found within this triangle. So, within the posterior triangle, we have the ischoanal fossa, which are two fat-filled wedge-shaped spaces found on either side of the anal canal and form the bulk of the posterior triangle. So each fossa has skin as its superficial base, whereas its deep apex is formed by the junction of the levator ani and the obturator internus muscles. Other borders include laterally the obturator internus muscle fascia and ischial tuberosity, inferomedially the anal canal and sphincter complex, superomedially the inferior fascia of the downwardly sloping levator ani, and posteriorly the gluteus maximus muscles and sacral tuberous ligament, and anteriorly the inferior border of the anterior triangle. So the fat found within each fossa provides support to the surrounding organs, yet it allows rectal distension during defecation and vaginal stretching during delivery. Clinically, injury to vessels in the posterior triangle can lead to hematoma formation in the ischoanal fossa and the potential for large accumulation in these easily distensible spaces. Moreover, the two fossae communicate dorsally between the anal canal or behind the anal canal. This can be especially important because an episiotomy infection or hematoma may extend from one fossa to the other. Now, another component of the posterior triangle is the anal canal, and this distal continuation of the rectum begins at the level of the levator ani attachment to the rectum and ends at the anal skin. Now, along this 4 to 5 centimeter length, the mucosa consists of columnar epithelium in the uppermost portion. However, at the pectinate line, also termed the dentate line, simple stratified squamous epithelium begins and continues to the anal verge. At the verge, keratin and smooth adnexa join the squamous epithelium. Now, the anal canal has several tissue layers. First layer is the inner layer, which includes the anal mucosa, internal anal sphincter, the intersphincteric space that contains continuation of the rectum's smooth muscle layer, and an outer layer that contains the puborectalis muscle as its cephalad component and the external anal sphincter caudally. Within the anal canal, the three highly vascularized submucosal arteriovenous plexuses termed anal cushions aid complete closure of the canal and fecal continence when opposed. So we have increasing uterine size, excessive straining, and hard stool that's create increased pressure that leads to degeneration and subsequent laxity of the cushion supportive connective tissue base. These cushions then protrude into and downward through the anal canal, and this leads to venous engorgement within the cushions, which we now term hemorrhoids. Now, venous stasis results in inflammation, erosion of the cushion's epithelium, and then bleeding. External hemorrhoids are those that arise distal to the pectinate line and covered by stratified squamous epithelium and receive sensory information or innervation from the inferior rectal nerve. Accordingly, pain in the palpable above the pectinate and are covered by insensitive inner rectal mucosa. This may prolapse or bleed but may rarely become painful unless they undergo thrombosis or necrosis. Now, another component of the posterior triangle is the anal sphincter complex. Two sphincters surround the anal canal to provide fecal continence, the external and internal anal sphincters, and these sphincters lie near the vagina and may be torn during vaginal delivery. The internal anal sphincter, or the IAS, is a distal continuation of the rectal circular smooth muscle layer. It receives predominantly parasympathetic fibers, which pass through the pelvic sphinctic nerves. Along its length, this sphincter is supplied by the superior, middle, and inferior rectal arteries, and the IAS also contributes the bulk of anal canal resting pressure for fecal continence and relaxes prior to defecation. It overlaps the external anal sphincter for 1 to 2 centimeters. Now, the distal site at which this overlap ends is called the intersphincteric groove and is palpable on digital examination. The external anal sphincter, on the other hand, is a striated muscle ring that anteriorly attaches to the perineal body and posteriorly connects to the coccyx via the anococcygeal ligament. The EAS maintains a constant resting contraction to aid continence, provides additional squeeze pressure when continence is threatened, yet relaxes for defecation. The external sphincter receives blood supply from the inferior rectal artery, which is a branch of the internal pudendal artery. Clinically, the IAS and the EAS may be involved in third and fourth degree lacerations during vaginal delivery, and reunion of these rings is integral to defect repair. Next, we have the pudendal nerve, and this is formed from the anterior rami of the S2 to S4 spinal nerves. It courses between the piriformis and the coccygeus muscles and exits through the greater sciatic foramen at a location posterior to the sacrospinous ligament and just medial to the ischial spine. Thus, when injecting local anesthetic for a pudendal nerve block, the ischial spine serves as an identifiable landmark. The pudendal nerve then runs beneath the sacrospinous ligament and above the sacrotuberous ligament as it re-enters the lesser sciatic foramen to course along the obturator internus muscle. Atop this muscle, the nerve lies within the pudendal canal and is also known as the Alcock canal, which is formed by splitting of the obturator internus investing fascia. In general, the pudendal nerve is relatively fixed as it courses behind the sacrospinous ligament and within the pudendal canal. It may be at risk of stretch injury during downward displacement of the pelvic floor during childbirth. Now, the skin of the anus, clitoris, and medial and inferior aspects of the vulva is supplied primarily by distal branches of the pudendal nerve. Now, as the pudendal nerve leaves the Alcock canal to enter the perineum, it divides into 3 terminal branches. The dorsal nerve of the clitoris, which is also what we call the terminal branch of the deep perineal nerve, runs between the ischiocavernosus muscle and the perineal membrane to supply the clitoral glands. Now, the superficial perineal nerve runs superficial to the perineal membrane, and it divides into posterior labial branches and muscular branches, which serve the labial skin and the anterior perineal triangle muscles respectively. The inferior rectal branch, or what we call the inferior hemorrhoidal nerve, runs through the ischoanal fossa to supply the external anal sphincter, the anal mucosa, and the perianal skin. The major blood supply to the perineum is via the internal pudendal artery, and its branches mirror the divisions of the pudendal nerve. Now, that's it for my lecture, and thank you for watching this lecture. And please don't forget to subscribe in my YouTube channel and my WordPress site, Doc Ina Obigayne. Thank you!